And now it's my pleasure to introduce our first speaker, Fred Masudi. Fred is a practicing cardiologist at the University of Colorado, where he's professor of medicine. He is recognized as a leader in cardiovascular outcomes research. He previously served as chair of the ACC-AHA Task Force on Performance Measures. He currently, in his spare time, serves as the NCDR Senior Medical Officer and is chair of the Science and Quality Oversight Committee, and he also serves as the vice chair of the AHA Quality of Care and Outcomes Council. It's a pleasure to have you, Fred. Welcome to Central Oregon. Thanks for coming.
Thanks, Mike, and thanks everyone for having me here. I have to say this is the first time I've been to a place where I get an aspirin pod as a door prize. I hope it isn't because you expected me to have the big one up here, but we'll see. Just to get a feel for who's here, can you raise your hand if you're a nurse? Terrific. And what about if you work with an EMS system? Great. A physician? All right. Anyone else that I've... What do you do? Data analysis? Okay, terrific. Very important. And someone back there as well? Oh, terrific. Okay, great. Well, good mix of people here. All right. Oh, must be my broker. Okay, so, all right. So thanks for having me to Oregon. It's like a second home. I've enjoyed many sites in your neighborhood, so thanks for having me here. So we're all here for the same reason. We're all here because we serve different roles in the health system, but our goal is to deliver the highest quality care to our patients, which means that we strive to deliver effective, safe, efficient, timely, equitable, and patient-centered care. And it doesn't matter if we're a nurse or with EMS, or doing data analysis to support quality improvement, or with the public health department. This is a common goal that we share. And you know, this issue of quality is not a new idea. Actually, the modern quality movement started with the nurse. So here's a hand to the nurses. It started with Florence Nightingale during the Crimean War, where Florence Nightingale had the audacity to start to look at the extent to which patients in the hospitals, in military hospitals in the British Army, were dying because of injuries, dying because of wounds, and dying because of disease. And what she found was that the very small minority of injuries were occurring on the battlefield. And most military deaths occurred because of unsanitary conditions in the hospital, really what could have been preventable and unnecessary deaths. And this was back in the 1850s. And Florence Nightingale said the very first requirement in a hospital that this should do the sick no harm. And that's an idea that, you know, she actually got a fair amount of heat for. You know, that she would go out and have the gall to criticize what was going on in the hospitals. Similarly, Ernest Codman, a surgeon in Boston in the early 1900s, he, like all of us, was human and made mistakes, as this article says. He was sufficiently disgusted with the lack of outcomes evaluation and care at the Massachusetts General Hospital, which was, just like now at that time, a very respected institution, that he resigned and he started his own hospital that was called the End Results Hospital. And the difference between Codman's hospital and our hospitals, your hospitals and my hospitals, is that he admitted his errors in public and in print. So they would have meetings and they would say, you know what, we screwed up. We misdiagnosed. We actually operated inappropriately on this patient. Or we did the wrong thing post-operatively and the patient died. It was all out there on the table. Well, on fateful January 6th, Codman, who was the president of the State Surgical Association, presented a cartoon at the meeting portraying the local surgical society. And I didn't have a high enough resolution picture to show you this cartoon of a picture of a goose laying golden eggs with its head buried in the sand. It portrayed greedy surgeons grasping for gold from wealthy patients, and he was trying to get his end result message across and created an uproar. He was challenging the surgeons in his state to do the same thing that he was doing. He was ostracized for this, public insult by his colleagues, and his income that year plummeted, and he was ordered to step down as chair of the State Surgical Society. He never stopped his effort to measure, to report, and to improve. Perhaps someday we'll catch up with his work. As you can see, that made him old, all that effort. And as you can see, he was also considered one of the martyrs of the safety and quality movement. Well, and after that time, there have been a couple of typical reactions to this issue of measuring quality of care and being open about it. One of which is denial, this idea of sticking their head in the sand. The other is anger. This is what's now my 3-year-old at her first birthday. I don't know why she's so upset. But that is has been a typical professional response to this measurement of quality up till relatively recently. And we spent a lot of time saying, just like Mark Twain, you know, nothing needs improving so much as other people's habits, right? The quality is not my problem because I know I'm a good doctor. I know I'm a good nurse. I work in a great EMS system. It's other people's problems. You know, it's really an issue of the bad apple, right? It's that hospital across the street that I compete with. They're the ones that are doing the low quality work. That was the perception after Codman. That really it was an issue of someone else's problems. But then there became this, and you know, this is what George Bernard Shaw said, it will do you no good if I get over this. A doctor's reputation is made by the number of eminent men who die under his care. And that's what things used to be like, right? But we had to recognize that things had to change. And one of the ways things changed were national quality movements like the Cooperative Cardiovascular Project, Medicare, started to measure the quality of care for myocardial infarction across the nation. And what they found was it wasn't other people's habits that needed changing. It was all of our habits that needed changing. You know, if you look at beta blocker use across the country, sure, there were some states doing better than others. Sure, Maine was doing better than, say, Nevada. But everyone had significant room for improvement. So a recognition that quality isn't an issue of finding the bad apples. It's finding approaches to care that provide a rising tide to lift all the boats, not just to pick out the bad actors. And this has led to some degree of a conceptual realignment. I think we're now in that stage of grief, what do you call it, acceptance, I guess, where people recognize that measuring and improving quality of care is part of the fabric of the medical profession. It's part of our professional responsibility. It's part of what we're meant to do. As you can see also, there's this recognition that quality measurement and improvement is an important part of the scientific life cycle in medicine. And understanding that by working on quality and improving quality, we contribute to the advancement of knowledge. And we also contribute to making sure that we go that last mile, where we take all the effort that is put in by the patients in the studies that establish the benefit of fibrinolysis or establish the benefit of primary PCI. We do those patients honor by going the last mile and making sure that these things are implemented in practice. But how do we know if we're doing well? Well, obviously there's no way to do that if we don't measure what we're doing. We have to measure to understand. And we're lucky in cardiology in that we have an incredibly robust scientific evidence base. I'm so glad to be a practicing cardiologist as opposed to, say, a rheumatologist. No offense to rheumatology, of course, but I have this tremendous evidence base from which to work. And we also have very robust evidence-based guidelines to guide what we're doing. But we also have to recognize that the evidence and the guidelines aren't enough. It didn't take long after these guidelines were developed, these incredibly elaborate, beautiful ACC-HI guidelines that went into great detail on the care of patients with myocardial infarction, sent out all over the place. And they just gathered dust on the shelves. And that's because there was no understanding of how to move these guidelines into practice. And again, one of the most fundamental ways to work on moving this evidence base has been worked on so hard, and to which so many patients have contributed into practice. And that is really where the registries come in. our capacity to measure and understand how we are doing in terms of moving that scientific evidence into practice. Now, the NCDR is now comprised of 7 registry programs, the first of which is the cath-PCI registry. How many of you who work in hospitals where you use the cath-PCI registry? So quite a few. The ICD registry, care registry, and then the Action Get With The Guidelines registry, which is obviously more of the focus here today. These programs focus on different aspects of cardiovascular quality. Some of them are procedural, some of them disease-based. They all involve important and strong collaborations with partner organizations, including the AHA in the Action Get With The Guidelines registry. And these registries are now used in more than 2,400 hospitals by more than 1,000 cardiologists and thousands of nurses and other members of the care team, and include more than 20 million patient records. It's actually probably close to 25 million now. And as you can see, various degrees of participation. cath-PCI and ICD are both the largest registries, but Action is not that far behind. It sounds like there's more work to be done, not only here in Oregon, by the way, but also in other states, including mine, in terms of Action participation. As you can see, the number of hospitals enrolled in Action has increased throughout time, reaching here in this graph over 700. It's now over 800. Nearly 500,000 records have been entered into the Action Get With The Guidelines registry. And the registry performs multiple important functions, including the basis of the D2B initiative, which I'll mention briefly later. Quality dashboards, another issue that I'll mention, which is an important means of obtaining feedback on your data more quickly. Users group meetings, recognition status maintenance certification, which is an important thing for the physicians in the group at very least. Also collaborations with states, specific states. Maryland is using this statewide. I know that there's a goal to do this statewide here in Oregon, which I think is a laudable goal. Integration with the AHA's Mission Lifeline program and so on. It's important to recognize that registries are not just observational studies. This is not just a time-limited cohort of patients with myocardial infarction we're going to measure for a couple of years, and we're going to take that data and do some stuff with it, and then it's going to go away. That's not the point. A registry is an observational database, to be sure, but it uses standardized data definitions that I'm sure those of you who are involved in data collection understand. And is used for quality assessment, quality improvement, and clinical research. And we'll start sort of in a little bit of reverse order. The NCDR has been a very important engine for understanding care and outcomes of patients with cardiovascular disease nationwide. It's now responsible for more than 200 peer-reviewed papers, all as a result of these enormous, dedicated communities of care that are working together to contribute information on the patients they care for in a systematic way. This is an example, some of the most important research I think that has come out of Action Get With The Guidelines, which is a study that Tracy Wong from Duke led with a number of others, assessing patterns of door in, door out time within Get With The Guidelines. And as you can see, there's a fairly broad distribution of door in, door out times within Action Get With The Guidelines. Sure, there are about 10% being transferred within half an hour and a huge tail after that. It's important also to recognize that, and you can see that in terms of the time to reperfusion, where you look at the 90-minute cutoff, obviously patients who present to STEMI receiving centers, the hospitals with PCI capability, substantial number of patients getting PCI within 90 minutes, not the case for patients who are being transferred. And this has implications for patient outcomes, in that it's very clear that when you have a door-in, door-out time of 30 minutes, and you compare that to longer door-in, door-out times, there's no doubt the mortality is increasingly high. Not terribly surprising, but to understand the magnitude of the difference here, where if you're transferring patients outside of 90 minutes, you're talking about doubling almost the patient's risk of dying. An important insight from the registry, again, based on having national representative data in a registry. Obviously, one of the most important local purposes of a registry is this idea of quality feedback and benchmarking. And how many of you have seen an executive summary from at least one NCDR registry in your hospital? How many? And how many of you who are non-physicians work in a site where you have had access to these data and you think the physicians have had nothing to do with it? Wow, okay, that's impressive. I'm glad to see that, because that's not the case nationwide. And it wouldn't be surprising to me if Oregon were ahead of the curve with respect to a lot of this. But one of the big challenges with the registry, I think, has been engagement of the physicians who are involved in care, where the nurses and quality managers are really into it, doing their jobs, getting stuff done, and the physicians are looking the other way. So I'm glad to see that that doesn't seem to be a problem, at least in this audience. One of the issues, though, with this data feedback process that the NCDR has used historically has been that you would get reports on a quarterly basis on data that were a little bit old. But this has now changed recently, and I don't know how many of you have had the opportunity to look at the ACCC Get With the Guidelines dashboards. Has anyone here had a chance to look at them? Like 2 people. Wow. So obviously an opportunity, and hopefully something you can go back to your institution and take a look at. The ACCC Get With the Guidelines now through the NCDR website, you can, using institutional sign-ons, get these dashboards where you can get flexible feedback on the results of your data from ACCC Get With the Guidelines. You can get electronic reports, comparator reports. You can compare yourself. Obviously, the comparators are not necessarily going to be named. We'll show you a few examples of that. You can get all the executive summary metrics, and you can get drill downs at the patient level for each of the metrics. And you can, again, with these comparator reports, define the peer groups and apply a variety of different filters to look at these data. This is just an example. This is one of the screenshots where you can see you have just these busy dashboards that include a variety of electronic reports. You have your submission status, get your data quality status, determine what type of submission your hospital is performing. You can get your outcomes reports that can be pulled out of in PDF format. You can get Mission Lifeline reports, so separate system reports if you're a participant in Mission Lifeline for your entire system, and specific reports on excessive dosing of antithrombotic and anticoagulant agents, and slide sets on your outcomes reports. If you want to go to your hospital administration, you want to say, this is the work we're doing, you can download slide sets from this tool, this dashboard. There are a variety of different metrics, including the different composite measures, and those little arrows show where your hospital is relative to the benchmark. In the United States, the measures on arrival, the measures at discharge, and so on. All of those things are available through the dashboard. You can also, as I said, drill down on the patient level, because I think sometimes when you see an outlier, you're wondering what the heck is going on. Is that something that we really did wrong, or is it something that maybe was missed in data abstraction? So you can go through on a patient level and identify where the gaps of care were, facilitates root cause analysis, also make sure that you do your part to ensure that the data that you're entering into the registries is as good as it can be, and get information on just about any metric, again, at the patient level using this tool. You can download graphs, as I said. You can put these into slides. Let's see. And then there's a comparator approach where you can slice and dice the data however you want. You can say, I want to compare myself with a variety of different types of hospitals, different peer groups, using various different approaches. You can see if you can compare yourself with other hospitals that only have diagnostic cath services or PCI services in different hospital locations. And you can compare yourself with different states, different beds. So it's a very flexible tool whereby you can not only look at the quality of care you're delivering, you can not only assess it at a patient level, you can not only take that data and download it and use it for the purposes of providing to your hospital administration solid evidence of the great work that you're doing, but you can also slice it and dice it in various different ways. As I said, of course, measurement is great and measurement is important and it's necessary, but it's obviously not sufficient. And so really the measurement is a means and not the end. So measurement is the first step that leads to control and eventually to improvement. If you can't measure something, you can't understand it. If you can't understand it, you can't control it. And if you can't control it, you can't improve it. But the goal is not to measure. The goal is to improve. And I don't know how many of you were participants in the D2B initiative, but I think this is one of the striking accomplishments in cardiovascular quality over the last decade, probably quality in general over the last decade. We saw gratifying improvements in the time to PCI in patients who presented to PCI-capable hospitals, to the point where this door-to-balloon or door-to-device within 90 minutes at PCI-capable hospitals, it's one of these things there's been some talk about maybe not even continuing to look at it as a quality measure because performance is so good. But as we know, this was only part of the issue, right? We're talking about reperfusion in PCI-capable hospitals. This project, for all its assets, for all its achievements, wasn't looking at the system of care more broadly, talking about EMS systems, thinking about systems where you have patients who present with STEMIs but don't have the capacity to do PCI and need to think about transferring them for reperfusion therapy. And that's really where Mission Lifeline has come in. And Action Get With the Guidelines is the fundamental data engine under Mission Lifeline, as I know you all know. And I was glad to see that although it sounds like, as Mike outlined, there's still important work to be done in Oregon, just like there is in Colorado. And I'll say that we face many of the same challenges in Colorado as you do. I was just notified that we're putting together, our state legislature has mandated a STEMI task force be put together under the governor, because we face many of the same challenges that you do here. And again, one of our challenges is too that, the extent to which we have participation in a registry that allows us to measure and understand quality of care. The thing that's so important about Mission Lifeline and the role that Action plays in this program is that it really promotes teamwork. I think many of the physicians in the room may remember the days of this romanticized notion of sort of the whole picture of healthcare, the whole world of healthcare was this physician relationship with the patient. And that's not to demean the importance of the physician-patient relationship, still a very important aspect, but the fact of the matter is that's only one component of successful medical care. Because we all know that if we don't work well as a team, we don't work well, and we're only as good as our weakest member. And so one of the most important things about Mission Lifeline in my mind is this idea of the promoting teamwork, looking outside of just the physician-patient relationship and incorporating the entire healthcare team from the moment the patient calls 911 to when they get their PCI and their subsequent MI care. And there are some opportunities and challenges for registries as well that I'll review only briefly. In terms of one of the opportunities, there's a great opportunity for education. There are also some challenges in terms of data quality and this issue about what about electronic health records, and if we have Epic in our hospital, shouldn't we just abandon all the registries? Well, in terms of education, this is particularly relevant to the physicians. I don't know if you've been keeping track of what ABIM is doing, but ABIM is now mandating that instead of this every 10-year maintenance of certification cycle, we're going to need to get maintenance of certification, or MOC credits, on a rolling every 5-year basis. And part of those MOC credits need to be performance improvement credits. So they're getting away from this idea that all you need to do is pass a test and know a bunch of stuff about, say, 2B3A inhibitors and fibrinolysis and PCI. And these performance improvement credits can be pretty daunting. I know I just barely grandfathered out of them by some accident the first time around. But even the grandfathers, the so-called grandfathers, are going to have to get these credits, and they're going to have to get 20, I think, every 5 years. And again, this is where I'm grateful to be a cardiologist and not, say, a rheumatologist. Again, no offense to rheumatology, but here I have this mechanism whereby I can collect the quality of care in the system that I work and use that as a springboard to obtain ABIM MOC Part 4 credit. And this is going to be, when I think people really start to understand what this means, they're going to be incredibly grateful to have these data around, as opposed to having to squirrel around in patient charts in their extra time and trying to define some quality metrics and decide what to do. And so I think these, again, these registries will play an important role. I'm a general cardiologist, and that actually doesn't, and I'm participating with the EP folks at our hospital on some quality improvement using the ICD registry. And it doesn't matter, I'm not an EP. I'm part of the care team that's working with them on quality. And so every member of the team who is involved in the projects and involved and dedicated to trying to figure out ways to improve care can get credit. Which is another real bonus to this, is it recognizes the fact that quality, of course, is a team effort. What about this issue about health information technology and registries? And, is, Epic and these other EHRs going to render registries obsolete? I think a reasonable question. I think the answer to that is pretty much a resounding no, in that, obviously having the EMRs and even PHRs, so patient electronic health information, be very, very useful as a means of feeding a registry, but those data themselves are not enough. There's this structure that we need to have in terms of the data standards, the guidelines that support the evidence-based care, performance measures, appropriate use criteria in some cases, and risk models that all feed in to these registries and help support communities of care. So I think electronic health records actually represent an exciting opportunity for registries. They certainly don't spell the end of them as far as I'm concerned. And then finally, there's this issue that some have brought up about gaming, and I'll use a local analogy here. This is Matt Groening's work, of course, as you all recognize, C. Montgomery Burns, right? So, and he's a Portlander, right? I believe so, if I don't have that wrong. So we're all kind of concerned about, I hear this a lot about gaming, well, this other hospital's using this information. This is sort of the classic example of gaming. At 3 p.m. Friday, local autocrat C. Montgomery Burns was shot following a tense confrontation at Town Hall. He was rushed to a nearby hospital where he was pronounced dead, and he was then transferred to a better hospital where doctors upgraded his condition to alive. So this is sort of the classic example of gaming. Well, the good news about the NCDR and Action Get With the Guidelines in particular is the robust data program that underlies this. And this is really it's a bi-directional issue. There's sort of data quality from above, and we do a lot of work in terms of data quality from above, in terms of having data quality checks and range checks. We have an audit program, but there's also this concept of data quality at the ground level. And this is where those drill down menus, where patient level data are so helpful at making sure that your institution is providing the best data possible. And we do in fact have an audit program to address the issue of gaming, but this is really a pretty broad and important data quality program, and our audits would suggest the data are actually quite good. And if you look at the overall accuracy of data abstraction in cath PCI, ICD, and Action Get With the Guidelines, it was at or better than 90% in each of the cases. And this has been published in a recent article in JACC that John Messenger led that provides you with some ideas about the data quality program. I'd encourage those of you who are interested in it to take a look. This is not, you don't have to take my word for it. This, I think, has been greeted with a lot of enthusiasm, this recognition that the NCDR data, again, based on the hard work of everyone that participates in the program, is excellent data and provides the basis for understanding and improving quality. So, NCDR started in 1997 with a single registry, and now it includes more than 2,200 hospitals and 700 outpatient practices, and has been doing clinical research and has been collaborating with government regulators and collaborating with states and collaborating with institutions and supporting best practices, even doing post-market surveillance in some cases. And the NCDR has a bright future. It has a bright future because of the participants in NCDR. It has a bright future because of how programs like Action support Mission Lifeline and support robust programs of care that look to be going statewide here in Oregon. We address these, I think what you say, smart goals, Mike, that's right, they're very smart goals. And we shouldn't think that our efforts don't make a difference, because they really do. If you look at myocardial infarction death rates in 1995 in the dark bars, you can see that there were variation survival from anywhere from about 12% to 27% on a hospital level in 1995. And in 2006, that variation had dropped dramatically. Furthermore, the average survival in 1995, this is actually average mortality, it shouldn't say survival, was just about 20% at 30 days in the Medicare population. And that dropped to 15.8, or a full 3% in a period of 10 years. And, there were some developments, I think largely, there were some important developments in MI care, but nothing that would explain differences of this magnitude. And I think what explains it are efforts of people like you, the folks at my hospital and elsewhere that are dedicated to measuring and improving quality of care for patients with heart attack. This just can't be explained by technological advances. This is explained by getting the right treatment to the right patient at the right time. And what this means is that for every 33 patients who presented in 2006, one more would have been alive at that time than in 1996. That's a pretty remarkable number. And so with that, I'll thank you. I guess we'll take questions at the very end, but very much appreciate your inviting me here. It's wonderful to be in Portland, and I will now pass it off to, I guess, Manesh, or to Ty maybe first.